For the last half of the day, we're going to talk about hepatocellular carcinoma, and we're delighted to have Richard Finn from UCLA Department of Hematology Oncology. He's the director of the Signal Transduction and Therapeutics Program at the Geffen School of Medicine, so he's an academician, and he's going to give us some science on biomarkers and the response to therapy for HCC. So thank you very much. Welcome, Richard.
Well, thank you all very much for the invitation to be here. It's always a pleasure to address my hepatology colleagues. As you're very well aware, liver cancer is a multidisciplinary field, and there's those of us trained in internal medicine that play a role, and then those that are more procedure-oriented. And always a pleasure to talk to the internists, because I think we look at data a little differently. And I do have a lot of data to share with you, because the field of liver cancer has changed quite dramatically over the past few years. I consult for a lot of people. So this slide comes from a friend of mine, a colleague of yours, Dr. Singhal at UT Southwestern, who highlights the changes in cancer mortality over this past decade or so. And you can see that in medical oncology, we've made a lot of progress in many of the top malignancies in the United States, lung, colon, breast cancer. But liver cancer is still somewhat of an orphan disease, and as far as death rates, they continue to climb, right? And we know the incidence of liver cancer has been climbing because of the hepatitis C epidemic. That will probably change because of all the good work you guys have done. But still, NASH is expected to rise, and this death rate is not expected to change anytime soon. Now, the pathophysiology of liver cancer has been worked out very well. It's one of the few diseases we know what causes it. Chronic liver disease is a common denominator, and that over someone's lifetime, that chronic inflammation leads to a cirrhotic state, which is really a pre-malignant state. And the biology of the interactions between hepatocytes and the stroma has been worked out, and we have a very good understanding of the biology of liver cancer. And where a lot of cancer medicine has gone over the past decades has been moved beyond cytotoxic chemotherapy and develop molecularly targeted drugs that take advantage of this biology. And, if you're familiar, for example, breast cancer is no longer approached as one disease, right? We know breast cancer is estrogen receptor positive breast cancer, there's the HER2-driven breast cancer, then there's this triple negative group. And within those subclassifications, there's been drugs that are developed for specific patients. A patient does not come in and you say you have breast cancer, you need this drug. It's what type of breast cancer, what molecular profile of breast cancer do you have, and how does that influence your treatment? And liver cancer has not gotten there yet. It has gotten to the fact that when we look at liver cancer at the molecular level, and depending on the type of technology that's used, whether looking at just gene expression or DNA changes, epigenetic changes, and overlaying that with biologic phenotypes, we can see that liver cancer can be subdivided into several different groups. But as of yet, this has not affected clinical practice, and hopefully this will change in the future. One thing that has started to play a role, at least in drug development, is amplification of FGF19. This is a ligand for the fibroblast growth factor receptor, and there are drugs now in development that are very specific for FGFR4, and the biomarker for development of these drugs would be like FGF19 amplification or overexpression. But again, this is further behind in drug development. So when we think about staging liver cancer, in cancer medicine, we stage patients for a few reasons. One, to get prognostic information, and then also to be able to compare research, that we're talking the same language when we're talking about a group of patients. And in that regard, the Barcelona BCLC staging system has really become the standard, I think, for talking about this disease. And the reason it took hold, certainly in clinical trials, is that it does separate patients very well as far as prognosis. And the prognosis in liver cancer, as all of you know, is not the function of just the tumor characteristics. Again, if we look at any other malignancy, the staging system is TNM, tumor known metastases. And that can predict very well for outcomes. But in patients with liver cancer, the other competing risk for death is their cirrhosis. So by Barcelona, patients are initially assessed by their Child-Pugh score and then by their performance status, two things that are very prognostic in liver cancer, and then characteristics of the disease. And not to go over this in great detail, I'm sure many of you are familiar with it, but clearly patients who are early stage should go to curative treatments, resection, transplant. The big group of patients that we've been trying to improve on are the intermediate and advanced stage patients. And this is an area of growing data and an area of some debate, I think, if you talk to an interventionalist or someone who is in cancer medicine, is this gray area between intermediate and advanced. Because strictly speaking, patients with liver cancer who have disease confined to their liver can be advanced, right? They can be advanced if they have macrovascular invasion. And MVI is a very important prognostic factor. And that doesn't mean just V4 invasion or V3, but even V1 invasion, right? These are patients where we know do not benefit as much from chemoembolization versus those who don't have vascular invasion. So for all your patients who have intermediate disease, if they're not cured, they will migrate to advanced stage, right? If they don't die of cirrhosis. So for your Child-Pugh A, well-compensated patient, multifocal, they get local regional therapy, and maybe they have recurrence, they'll get LRT again, but at some point they'll develop a contraindication LRT, either extrahepatic spread or MVI. And for a decade, until 2017, sorafenib was a standard of care for those patients. And sorafenib has been shown repeatedly to extend survival. Now, it did that without inducing response rates, and if we look at the SHARP study, which all of you are familiar with by now, which was a North American European cohort, the median survival from placebo, and at the time in 2007, there was no systemic treatment that had ever been shown to improve survival. Therefore, placebo was the control arm, and the study was stopped early because of a 3-month median improvement and a hazard ratio of 0.69. So a 31% decrease in the risk of death. And similarly, in the Asia-Pacific cohort, we saw the same magnitude, 0.68. I want to call your attention to just the control arms here because the natural history of liver cancer has changed over a decade. In North America, it was about 8 months, the placebo arm, whereas here it was 4 months. Even though these were all Child-Pugh A patients, Barcelona stage C, and it reflects practice patterns, right? In Asia-Pacific, TACE and LRT was a dominant modality. And keep in mind, before we had drugs that improved survival, TACE expanded to fill that void, right? And, patients who were beyond criteria of benefit from TACE continued to get TACE because there was nothing else to offer them. However, as we look at modern data, I want to call your attention to the survival of patients from both areas. So after 2007, there was a large effort to do better than sorafenib. We needed a drug better than sorafenib, and we needed drugs after sorafenib progression. And I actually joined the UCLA program when I finished my fellowship in 2003, and have actually seen a lot of this evolve over time. Unlike other malignancies where a lot of the data was developed in prior decades, liver cancer really has evolved during my career. And you can see that a number of drugs had failed. And just in the past 2 years, we've seen a number of approvals and phase 3 data. So the first drug to be approved in frontline after sorafenib was lenvatinib. And lenvatinib, like sorafenib, is an oral multikinase inhibitor. These drugs are very dirty, right? They're small molecules that hit a lot of different proteins. So it's a little hard to say exactly what these drugs are doing in any given patient. And if we look at the kinase profile, right, so in the lab, what do these drugs do? Clearly hitting the VEGF receptor is an important part of treating liver cancer, and that's a common denominator for many of the drugs, is that they hit the vascular endothelial growth factor receptor. And lenvatinib is very potent for that family as compared to sorafenib, but similarly is very potent against FGF. And FGFR has been implicated as a driver in liver cancer. We talked about FGFR4, but we also know that FGFs play a role in resistance to anti-angiogenic approaches. And then there's another number of other targets that are hit, and their relevance in liver cancer just is not fully known. So the Reflex study was a global open-label study looking at lenvatinib versus sorafenib. It's important to note, for those of you that might use this drug, that is dosed by weight, right? 8 milligrams or 12 milligrams based on the patient's weight relative to 60 kilos. And this study had typical inclusion criteria. Patients had to be Barcelona B or C. So keep in mind, Barcelona B are intermediate patients, and if they progressed on TACE, then they would be a candidate for this study. Child-Pugh, good performance status. This study excluded patients who had VP4 or main portal vein invasion. That was unique to this study. Usually those patients are included. That's a very bad risk group. And also patients who had more than 50% of their liver involved. So the main endpoint, and just so we can speak the same language here as far as cancer research, is this idea of RECIST versus modified RECIST, right? So how do we assess response in cancer clinical trials? Historically, we measure the length of a tumor and call that the sum of the longest diameters, right? So we pick a few target lesions in the liver or the lung, add that up, and if we see 30% decrease in the sum of the longest diameters, then we call that a partial response. If the SLD increases by 20%, we call that progressive disease. And then anything in between would be stable disease. If things completely disappear, we would call that a complete response. What was noted, and it really comes from the TACE literature, right? So with TACE, and all of you know that liver cancer are hypervascular on their arterial phase, right? That with TACE, tumors don't necessarily shrink, but they lose their enhancement, right? So EASL criteria was developed to capture response with local regional treatment, right? And instead of just measuring the size of the total tumor, they just measure the size of the enhancing part, right? And so a patient who has a TACE and 80% of the enhancement goes away would be considered a partial response. But it was also noticed, initially with sorafenib and then with other molecular therapeutics, that these drugs could have a similar effect on tumors in the liver, that you could lose the vascular component. And that was felt to be biologically and clinically important. And so therefore, the modified RECIST criteria was developed, which instead of just measuring the sum of the total tumor, here you would measure just the longest diameter of the enhancing component. So in this study, the primary endpoint was overall survival, and it was powered for non-inferiority. So non-inferiority says we're going to set a limit on the confidence intervals, and as long as you fall within the upper limit of that confidence interval, we'll say you're non-inferior. It doesn't mean you're better. It doesn't mean you're equivalent. It just means you might be a little worse, but we're willing to accept that. And when I say a little worse, is in this study, the upper limit of the confidence interval could be 1.08, right, to be non-inferior. And there were other studies that used this benchmark of 1.08. At the end of the day, this hazard ratio was 0.92, and the upper limit was 1.06. So this study was able to statistically call non-inferiority. And here with lenvatinib, we saw survival was 13.5 months, sorafenib 12.3. So look here, now sorafenib survival is over 12 months, whereas before we had seen it was 10.7, 10.9 in the SHARP study, and this was a global study. And when we look at the subgroups, again, the hazard ratios here are all very consistent with this non-inferiority aspect, but I want to call your attention to some groups here, and what was nice about this paper is that it listed both the survival for lenvatinib and sorafenib. So if we look at this group of patients who have bad characteristics, MVI, macrovascular invasion, extrahepatic spread, or both, if you don't have those, survival was about 18 months in both of these groups. So this is that group of patients who are still confined to the liver that some people might go ahead and do Y90 for, and as you may be aware, there's been 3 negative phase 3 studies with Y90. But here we have survival data of up to 18 months. And that's similarly looking at the stage B patients, survival 18, 17 months each. So what was interesting is while survival was non-inferior, secondary endpoints were superior for lenvatinib. So again, using modified RECIST criteria, we see progression-free survival was about doubled from 3.7 to 7.4 months. And if we look at responses, and this was done by a blinded review by Riccardo Lencioni, a very distinguished interventionalist. So the response rate for lenvatinib by MRECIST, the investigator, was 24%. By independent review, it was 40%, and I think this speaks to the challenge of using MRECIST in the community, certainly at any center that has good liver cancer radiology, it isn't a challenge, but I think in the community it can be. But even by conventional RECIST, responses were about 19%. This is the first time we have a drug that's giving real responses in liver cancer. And that's compared to sorafenib, where MRECIST was 9%, and here we see the conventional RECIST 6.5%, very consistent with the SHARP study. And this data was presented at our GI ASCO meeting earlier this year, just asking, regardless of which drug you got, if you had a response, did that mean you did better, right? Because we know in cancer medicine, just because a tumor responds doesn't mean you live longer. And that's why the FDA often does not use response as a way to approve drugs, because it doesn't correlate necessarily with survival, which at the end of the day is the most important thing we want to do for patients, right? We want to improve survival. We don't want to improve their CT scans. We don't want to improve their MRIs. We don't want to just decrease enhancement. We want them to live longer. And so here you see that patients who had a response, regardless if they got len or sorafenib versus non-response, very different in their survival. Now, this did not look at patients who had progression, or I guess the progression patients are in here, but the stable disease patients, what was their survival, we don't have here. But needless to say, if you respond, your survival is 22 months, right? So again, I just want to point out the evolution in survival for patients with liver cancer. And so these drugs clearly have side effects that can be significant. Sorafenib, as many of you know, the big problem has been hand-foot skin syndrome and GI toxicity, diarrhea, fatigue, weight loss. And what's interesting is that both drugs can cause hypertension. That's a class effect of VEGF inhibition. However, lenvatinib has a much higher incidence of hypertension, and as you use this drug, you need to be cognizant of that. Because for sorafenib, it does cause hypertension. Most of it is generally low grade, but this drug is a very potent inhibitor of VEGF receptor, and we do see hypertension, and we also see proteinuria. And again, that is something you need to monitor. How you react to that is not exactly clear. For a group of patients who are sick, the significance of proteinuria is not really clear clinically how it will affect them. But certainly if someone is nephrotic, you would certainly have to hold drug and back off. What's interesting, though, is lenvatinib does not have a high frequency of significant hand-foot syndrome, right? So that differentiates this drug from sorafenib. And both of these drugs would be considered reasonable choices, standard of care frontline. So second line, we've had a lot of drugs approved. The first would be regorafenib. This drug was looked at compared to placebo. The first time we saw a drug that improved survival after sorafenib. So patients progressed on sorafenib. They were randomized to rego or placebo. These patients were required to have tolerated sorafenib before coming forward. It was a well-balanced study. This study took most of the patients from outside Asia, and all the studies differ by their percentage of Asia and North America, Europe contribution. But needless to say, this study improved survival. The hazard ratio is 0.62, so a 38% decrease in the risk of death, and again, about a 3-month improvement in median OS. And the toxicity of this drug is fairly similar to sorafenib. It, again, is a very potent VEGF receptor inhibitor as well as other targets. And we still see HFSR, fatigue, hypertension, things that we need to be aware of. So the next drug that was approved for advanced liver cancer was cabozantinib. Cabo, again, is a small molecule. It hits the VEGF receptor, but unlike other drugs, hits the hepatocyte growth factor receptor, or c-MET, as well as another tyrosine kinase axle, and was looked at versus placebo in a group of patients who had progressed on sorafenib. This study here, you see, had a large North America, European cohort. And survival was on par, I would say, with the Rego data. The hazard ratio is 0.76. Here you see the placebo arm did 8 months to 10.2 months. This is incremental, right? This is not a cure, but these are incremental changes that are, hopefully I'll convince you, that are helping people with liver cancer live longer. But keep in mind, to get a benefit from these drugs, they need to be well compensated. And in order to get patients to second line, they first have to get to front line. And I need to urge all of you to reconsider when we stop local regional therapy, right? The data to continue local regional therapy beyond progression is not there. And now we have high-level evidence, phase 3 randomized studies here published in the New England Journal of Medicine that are showing that we're improving survival for patients. And this study improved PFS, more than doubling of progression-free survival. So you can see in the placebo arm, they progress very rapidly, and that's attenuated with cabozantinib. And again, interestingly, like Rego, like sorafenib, Cabo is improving survival without inducing significant responses. It's slowing progression. And when we think about this class of drugs, which are cytostatic drugs, they're not cytotoxic, right? Chemotherapy, in the age of chemo, we wanted to see tumors shrink. But keep in mind, chemo shrunk tumors but did not improve survival. The toxicity with this drug is fairly similar to the other TKIs, hand-foot syndrome, hypertension, GI toxicity. So ramucirumab is another drug that was approved earlier this year. Ramucirumab is a monoclonal antibody. So this drug is different from the other drugs we've talked about in that it's intravenous and it's very specific, right? It's not promiscuous like the kinase inhibitors. This drug binds to the VEGF receptor and blocks ligand binding. And there was a very large phase 3 study that looked at ramucirumab versus placebo, and it was a negative study, a negative phase 3 study, the REACH study. Retrospectively, they looked at AFP as a baseline factor and activity. So you can see in those patients who had a high AFP versus a low AFP, it was prognostic. Placebo lived 4 months. Here they lived 12 months. Now, in the low AFP group, ramucirumab had no benefit, but in this high group, there was an improvement in survival. And so this led to a repeat study, the REACH-2 study, which looked at ramucirumab versus placebo in a biomarker-selected population. The first time we've incorporated a biomarker into selecting patients. So these are patients who had sorafenib, progressed, and had a high AFP, and were randomized to RAM versus placebo. And this study did meet its endpoint of improving overall survival. Given the magnitude, 7.3 months versus 8.5 is not a dramatic difference, right? A 1.2-month improvement in OS. However, that is a hazard ratio of 0.71, which is a 29% decrease in the risk of death for this high AFP population. And what was interesting is there does appear to be a tail to this curve. If you look at 18-month survival, about 25% of patients on RAM are still alive versus only 11% in the placebo arm. What's interesting about this molecule is it's very well tolerated, right? Unlike the TKIs, which have hand-foot syndrome, diarrhea, other just these vague side effects, this drug is very specific. So the side effects we see are really related to interacting with the VEGF axis. So therefore, we see some capillary leak, edema. There's been some increase in ascites with this drug, also hypertension. But for patients who had been on a TKI for some period of time and have had trouble with those side effects, this would be a very reasonable option. So the big change in how we manage patients with cancer, certainly in other diseases, has been the development of drugs that target different axes of the immune system. And all of you are very familiar with immunology from your transplant work, that there's the activation phase and the expansion phase for a T-cell immune response. And several of the molecules that are involved in regulating this process are very well understood. And one of the first drugs to be approved in cancer medicine was ipilimumab, which was approved in melanoma. It blocks CTLA-4. It's a monoclonal to CTLA-4 and therefore prevents T-cell activation. It does have side effects such as activating the immune system to cause other problems, autoimmune problems. We can really see any organ system affected by these drugs. Neuropathies, diabetes, adrenal insufficiency, thyroid problems, autoimmune hepatitis. Then the second generation of drugs were these nivolumab and pembrolizumab, right? And you know the Nobel Prize last year went to James Allison, who was pivotal. One of the receivers of the award was James Allison, who was pivotal in recognizing the interaction between PD-1 and PD-L1 in regulating T-cell responses. And that led to the generation of these drugs that are monoclonal antibodies and disrupt this axis. And therefore, it's been identified that some cancers can evade the immune system by expressing PD-1, right? And by expressing PD-1 on the tumor cell, they can evade immune surveillance, right? It's kind of somewhat of a cloaking device. And that if you come in with an antibody to remove that evasion, you can then expose a cancer to the immune system, and therefore you can have an immune attack. And these drugs have been approvals in numerous malignancies. Initially in melanoma. Melanoma now has an amazing survival. Advanced lung cancer has been revolutionized by these drugs. And there's been data now in liver cancer. And I'm happy to share with you, you're probably one of the first US audiences to see the phase 3 data from Bev-Atezo that was presented at ESMO Asia a few weeks ago and will really be practice changing. So my colleague at USC, Anthony El-Khoury, was one of the first people to take a look at nivolumab in advanced liver cancer. He led this study, the Checkmate 040 study, which was really a safety study, but became the benchmark for the approval of nivolumab in advanced liver cancer. And in this study, what they saw, looking here at various populations, Hep B, Hep C, no hepatitis, and then a frontline population. But needless to say, in the second-line population, there were patients who had dramatic responses. And all of us who have used these drugs have seen a percentage of patients with advanced liver cancer who are probably cured, right? It's very dramatic. They feel better very quickly. Their tumors respond very quickly. If they have AFPs, they respond very quickly. And based on this data, nivolumab got accelerated approval, right? Not because the responses were so high, about 15, 20%, but they were very durable. If you had a response, the median duration of response was over 16 months. And again, some patients just don't respond. The challenge has been identifying these patients. We cannot pick them out of a crowd. We don't have a biomarker. And therefore, that is a risk in cancer medicine, and that goes for all targeted drugs. If you have a targeted drug, but you do a study that's untargeted, right? Your population is untargeted, there's always a risk that you won't meet your endpoint in a phase 3 study. And what was reassuring from this study was toxicity. You know, these patients were cirrhotic, they had viral hepatitis. That was always a concern with these drugs that, you know, we'd see bad outcomes. And in reality, that wasn't the case. We see things that are typical with this class, you know, hypothyroidism, rash is probably one of the most common events. We can see colitis, all these things that we need to be aware of. And there are changes in AST and ALT, which become a challenge. And all of you, I would urge you to become familiar with these drugs and these side effects, right? Because there will be some group of these patients who develop hepatitis. And whether it's autoimmune hepatitis, drug-induced liver injury, and it can become very confusing versus just the natural history of liver cancer progression, their liver starts to fail. And you should have a very low threshold for doing liver biopsies for these patients to help clarify that. And the guidelines, especially for patients who start with elevated AST and ALT at baseline and then they continue to rise, you know, in the use of steroids or Cellcept and things like that, you should become familiar with, because as these drugs become more and more used, you will be consulted more. So the FDA required Bristol Myers to do a phase 3 study. They had accelerated approval, and they did this frontline study of nivolumab versus sorafenib, Checkmate 459, a very eagerly awaited study, right? This was a frontline study to prove that nivo was really better than sorafenib. This study was presented at the ESMO conference just a few weeks ago, and this was a negative study. Everybody was quite shocked by this. Here you see survival with nivolumab, 16 months. Never seen survival of 16 months in a phase 3 liver cancer study. And with sorafenib, 14.7 months. Again, this is the same population, presumably, that was studied in SHARP. And you can see that the curves do not separate until later. And while there is some separation, it did not meet its endpoint. The p-value was 0.07. hazard ratio of 0.85. Now, PFS, there was no difference, right? We saw all the TKIs had a difference in PFS. And what was seen in many studies with immune checkpoint inhibitors, like Nivo and Pembro, is that there's a tail to the curve, right? PFS often does not separate, but what does separate is the tail, that as you follow patients out, there's a group of patients that just don't progress. In this study, that tail didn't necessarily mature as well. You can look at the follow-up here. This study followed patients up to 24, 36 months, a very long study to get to the endpoints, and at the end of the day, did not reach its endpoint. Now, we did see, there were more patients who had responses. 16% of patients had either a complete response or PR with nivolumab versus 7% with sorafenib, very consistent. And this really shows us that these drugs do induce responses. This was very similar to the phase 2 study that was published, Checkmate 040. However, there just wasn't enough of those patients probably to separate the curves. The other thing is there was a lot of crossover, unintentional crossover, right? Investigational agents, which was mostly IO, as well as confirmed immuno-oncology agents, 30% of patients who got sorafenib got these drugs second line, either through a study or through expanded access or approval, which also confounds things, right? I mean, because we're looking at overall survival, but if 30% of patients on sorafenib got this second line, that could confound the results. What was really nice about this study was the side effect profile. Here you see toxicity for Nivo and sorafenib, various toxicities, and the darker color are grade 3-4, the lighter color are lower grade toxicities, and you can see that the IO drug here, nivolumab, is very well tolerated as compared to sorafenib, but it did not meet its primary endpoint. So Nivo is still being studied, and I encourage all of you to look at this study. If you have patients in an adjuvant setting, patients who have a resection are being randomized to Nivo or placebo. Nivo is given once a month. It's very easy to give, and this clearly there's no standard of care for these patients who are high risk after surgery. Now, pembrolizumab is the other PD-1 inhibitor. This drug was looked at again in a single-arm study, very similar to Checkmate 040, and had very similar data in that the response rates were around 15 to 20%, and Pembro got accelerated approval in second line as well. We performed this study, unlike Nivo, which went to the frontline setting versus sorafenib. Keynote 240 looked at Pembro versus placebo in second line. This is the last placebo-controlled study that will be done in second line because we have so many drugs approved. And this study was published in JCO just this week. And similar to the single-arm phase 2 study, we saw response rates quite high, 18% responses with a duration of response of about 14 months for those who did respond. And here you see the survival curve, right? Median survival with pembrolizumab was 14 months. Survival with placebo was 10.5 months. The hazard ratio was 0.78 with a p-value of 0.0238. However, because of interim analyses and the statistical design plan, in order to be called positive, we had to have a p-value of 0.017. So even though there was a strong signal here and very strong likelihood that this is a real result, this study cannot be called positive because of the pre-specified statistical plan. But here, if we look at time to progression, we see that the median was not significantly changed that much. I mean, 2.8 to 3.8, that did reach statistics here. But what I want to show you is this tail to the curve. In this study here, 2 years out, you have a number of patients, about 18-20% of patients who just don't progress. And clearly, if we had a biomarker for who these patients are, then you could say, let's enrich for that population. But at this point, we don't know who those patients are. And so one of the strategies has been, if we don't know who's responding, can we just somehow increase the number of patients who are responding? And that's where combination approaches are being looked at. And one of those combination approaches is looking at targeting the VEGF axis. Now, this cartoon uses bevacizumab and atezolizumab, but it can really be adopted to any VEGF inhibitor. Because we historically thought that just hitting VEGF altered vessel angiogenesis, new vessel generation. But as it turns out, There's a lot of science now that hitting VEGF actually changes the tumor microenvironment, it changes T-cell repertoires, and can work synergistically with immunotherapy agents like atezolizumab or nivolumab, etc. So this study, which has gotten a breakthrough designation for the combination of lenvatinib, the TKI, and pembrolizumab. So this was a phase 1/2 study that's been going on for some time, and here using modified RECIST criteria, but I just want to concentrate on true tumor shrinkage, not the enhancement component. And you can see here that the overall response rate is about 33%, right? So single agent pembro and nivo is somewhere about 15 to 20%, and now when you add lenvatinib, those responses are up to 33%. Those are confirmed responses. And the duration of response is quite long. Here, at least 11 months, the upper limit still had not been reached. And here we have PFS of 9.5 months compared to 3 to 4 months with the TKIs alone, and median survival 20 months frontline. And this is a waterfall plot, and this just shows you each individual patient, tumor shrinkage. 30% would be a partial response. Anything above the line would be considered progression, and a number of patients have stable disease, right? But you can see a very significant number of patients getting a benefit. And there is similar toxicities with this drug as we've seen with the single agents, hypertension, AST, ALT elevations, diarrhea. So this led to this ongoing phase 3 study of len and pembro versus lenvatinib. The study's accruing. If you have patients, I still think even though we have a number of drugs available, they should go to clinical trials. Checkmate 040 is looking at ipilimumab and nivolumab. Ipi is a CTLA-4 inhibitor, so these are two IO agents together. And this data was just presented recently at ESMO, and you can see response rates with this combination are about 30%, and this is now moving into a phase 3 study as well versus sorafenib. And durvalumab, tremelimumab, so this is a PD-L1 antibody and a CTLA-4 antibody. This study is in a phase 3 study. Here we saw response rates of about 17%, not as impressive as some of the other data, but needless to say, has gone into phase 3. And this is that phase 3 design of the Himalaya study. It's finished accrual, and we're waiting for results. So bevacizumab and atezolizumab was studied in a small phase 1/2. So bev is an antibody to VEGF, otherwise known as Avastin. It's been approved for some time. And atezo is a PD-L1 antibody. And this study showed responses of about 36% that led to a phase 3 study, and for the sake of time, I'm going to move to the phase 3. But the toxicity with this combination was very similar to what we knew about bevacizumab: hypertension, proteinuria, fatigue. The incidence of rash or diarrhea is not that common. So this phase 3 study was just presented 2 weeks ago, and this was the first positive study in advanced liver cancer to beat sorafenib in more than 12 years. And here we took patients with atezo-bev, this is intravenous every 3 weeks, and randomized them to sorafenib. Very typical inclusion criteria. The endpoints were overall survival and PFS. Here's the breakdown of patients. They were mostly all Child-Pugh A. About 15% of patients were Barcelona B, that intermediate group. And you can see here by etiology, majority were Hep B, but Hep C and non-viral etiologies. So this study met its primary endpoint of overall survival. Here you see the survival with sorafenib, median was 13.2 months. And at a follow-up of 8 months, we still have not hit the median with the combination, right? So this is a hazard ratio of 0.58 versus sorafenib. We've never seen anything come close to this, and likely this will become the new standard of care front line. And we don't know yet what the true median is, but very likely it could be 20 months or so by the projection. And progression-free survival was improved by about 2 months. And what's really striking is response rate. Here we see by independent review, the response rate was about 27%. About 6% of patients had complete responses, 20% had partial responses, and the median duration of response still has not been reached. And this is really striking is the side effect profile is very comparable as far as incidence of any grade toxicity compared to sorafenib. However, if we look individually here, again, at specific side effects, compared to sorafenib, this regimen is quite favorable. Very low incidence of high-grade toxicities, hypertension. One thing to be aware of is there's always been a concern of BEV and bleeding events, right? Because it's a VEGF inhibitor. All these patients had to undergo an EGD within 6 months, right? So as this regimen rolls out, we all need to be very cognizant of that patients need to have endoscopies if they haven't had them. If they have varices, those need to be managed before starting treatment. And this will be a big teaching point, I think, as this rolls out. And really striking is patient-reported outcomes. If we look at delay, a deterioration in how patients feel, there was a marked improvement with this regimen versus sorafenib. And the last phase 3 study that's going on is this COSMIC study, which is looking at cabazantinib and atezolizumab versus sorafenib. This study's ongoing. How these studies will play out in the context of BEV and atezo being approved, we anticipate sometime next year. So now we have a lot of drugs, and will just exposing patients to more drugs improve survival? And whether patients get sorafenib or lenvatinib, there's a number of agents available second line. And as patients progress on these drugs, then likely they'll go on to get drugs they haven't seen before, right? And the assumption is that we will improve survival, but it's important that we select the right patients, right? Patients who are decompensated, it's going to be very hard to impact their outcome. So we need to triage patients. Every time we do an additional taste, you take away some of that patient's liver function, and the questionable benefit on overall survival has not been proven. And we've seen that, and when we look at this from the resource study, we published this for patients, and obviously this is a clinical trial population. But patients who got the sequence of sorafenib to regorafenib, median survival is 26 months. And again, a lot of that is patient selection, but it's also exposing patients to active drugs. So in closing, we have phase 3 data that now has supported the approval of 4 drugs. You know, for the first time, we have a highly active regimen that's superior to sorafenib. That's bev-atezo, and we're waiting for that approval. Level 1 evidence for single-agent PD-1 inhibitors has not materialized yet. Yet these drugs still have approval in second line, and I think are a reasonable option second line. And there's a lot of ongoing studies looking at novel combinations. So I thank you all for having me here. And I have to acknowledge a lot of my success has been from working with a very talented liver cancer team at UCLA. And all of you, many of you in the community refer patients to us as well. So again, thank you very much for your attention.